Well, welcome everybody to Lunch and Learn. I'm Denise James. I'm the Program Manager for the Program of Work at the Northern.
Sorry, just remember to press record. You start recording now.
I've done that, yeah. So is that too cloud,
yes.
Karen?
No,
is that
perfect.
too cloud? Yep, okay. Welcome everybody. Thank you for joining us today. We've got a really great presentation today from Colette Muir. But just before we do that, I just wanted to introduce the Paediatric Society and the clinical network, which is hosting the Lunch and Learns. And I wanted to really talk to you about the benefits of the Paediatric Society and some ways that it is actually useful for us as professionals, and particularly those of us that might not have considered joining the society before. So it's an organisation that working to progress health and wellbeing of tamariki and young people throughout New Zealand. It offers the opportunity to engage with other professionals with similar interests, special interest groups. Obviously, we've got the clinical networks that are producing up-to-date evidence-based resources for children, families and health professionals. And the other thing that you might not be aware of is that it offers the opportunity for education grants for all members through an application process as well. So there is the link there if you would like further information. The Lunch and Learn program, we've got the discussion page, which is the Padlet page, which has got the link that you can join. You can post questions there, and you can also provide feedback and share ideas through the mailing list that's there as well. What I also wanted to just talk to you about is that as we go through the presentation today, there's an opportunity for you to post questions. You can post questions into the chat, and we'll pick those up as we go along. The other thing I just wanted to mention briefly is that we have an opportunity for those that might want to get involved in and being a participant in organising and running these Lunch and Learns. We would really value having people come alongside and join with us. And if you are interested, if you could please private message in the chat today to Jane Hamer if you would be interested. And I guess there's really a number of things that are benefits to doing something like this, is that it is a professional development opportunity and provides a leadership opportunity as well as mentoring. So please consider that, and if you're interested, private message through to Jane. So thank you, and I would like to hand over now to Colette Muir, who's a developmental paediatrician at Starship Hospital, who will be speaking to us about transition of medical care for young people with developmental disabilities. So welcome, Colette. We are really interested in what you've got to say, and I'll hand over to you now for, yeah, and you can share your screen.
Kia ora koutou. It's a real pleasure to be here, and thank you so much for the invitation to speak today. This is a topic that is very dear to my heart, very much from a pragmatic clinician perspective, rather than any other perspective. And I'm pleased to say that the helicopter has just left, so you should be able to hear me, but let me know if there's any technical issues along the way. So what I wanted to talk about was the transition of medical care for young people with developmental disabilities. I'd like to acknowledge that whenever speaking in the disability area, I'm always very aware of languaging and words. I'm using the words developmental disabilities as a very general term to encompass a number of the children and young people that I look after. I think what I'm going to speak about today will hopefully ring true regardless of which young people you're working with in your practice. Oh, right. What is transition of medical care? So I, perhaps controversially, have very much picked a very old definition of transition here, that we're talking about the purposeful planned movement of adolescents with chronic medical conditions from child-centred to adult-oriented care, healthcare. Now, the reason I've done that is, of course, the definition of transition is far more broad than this, because our young people move from education sectors to other sectors such as workplaces. It's around psychological health and well-being, it's around medical health and well-being, it's around centering young people really in the centre. However, the focus I'm going to have today is that many of us in our practice will be involved in those far wider transitions. We may be working in schools, we may have a far greater role in the young people's lives. But where I want to really speak today is there's a bit of that whole transition puzzle that is actually our core business. As a clinician working in the healthcare sector or with a health focus in other sectors, we are often the one or part of a team needing to think about how that particular aspect of care, that part of the jigsaw puzzle, is going to be addressed within the adult-orientated healthcare system. And what I often see in transition is we can be so worried about the big picture and wanting to contribute to the big picture that we can at times, certainly myself, I can say, can forget about the bit that is our core business, or how we focus on our core business. So today is a narrow definition of transition. It's a narrow part of the transition, but it's the bit that I think, if we're working in the health system or working within health stuff in the education system, is the bit that we actually have to do, and we have to do well. Really, often what we're actually talking about is actually just providing developmentally appropriate, good quality care. So we know a lot about transition, and particularly if we think about the medical aspects of transition, and we know that there are a number of barriers, and I'm not going to dwell on those today because I think many of us are aware of them. There's a lot of research in this area. The particular barrier that I think is often really apparent to us working in the systems we do are the systemic barriers. So we know that services are often run quite differently in adult-oriented healthcare systems. They may often be siloed, they may not have a particular disability focus, and they may actually not provide the same types of services that we are doing. We know that transition is frequently done poorly, and in an inverse type of way, we know that the more complex medical needs are, or for that matter, social needs are, the less likely it is for the transition to be planned and done well. And this particular study about young people with autism spectrum disorder out of the US spoke to this very highly, that the young people least likely to even have the word transition discussed were those from African American background in that setting, and ones with higher or more complex need. So from clinicians, it's easier to do things that are easier and harder to do things that are harder. We need a lot of research on models of care and outcomes, and I think that when you look at the literature, there's a real predominance of literature that tells us about the barriers and much less literature that actually helps us with the models of care and the outcomes that we should be using. We also know our young people with disabilities are very high risks of unmet healthcare needs, of unmet medical healthcare needs. So, some studies of young people with intellectual disability, for example, have up to 40% of mental health disorders. We have to be very aware of risk-taking behaviour. If you have a mild intellectual disability, you're more likely to be a smoker, not less. We know that people with disabilities, even compared with other healthcare needs, are more likely to not receive transition services. And we also know that if you have a disability, you have a lower likelihood of accessing appropriate preventative healthcare services. And this isn't just nice to have. If you have an intellectual disability, for example, your long-term risk of early and amenable death is much higher than your same-age peer. One other thing I wanted to highlight before we discuss some practical tips today is the concept of transition versus transfer. So transferring of care, I am looking after this young person with regards to their respiratory needs, and I am handing that over to this particular adult physician or other clinician in the adult system. That's not transition, that's the transfer of care. And there's a flip here, that even if you don't have an easy transfer of care, we can still think about transition. So what do professionals tend to say? Professionals tend to say, transition's really hard, and they tend to say, in many areas, well, there's no one to transition to. And what I'd say to that is, that's true, often it's very true, but this is not a reason to do nothing. And so today I think what we're going to think about is some practical tips that even when the barriers are huge and the path is not easy, we can still do some things in our services to try and assist with this transition of medical care. Which is why I came up with a list of 10 practical tips for clinicians. And the idea is this is things that we can all do, regardless of our profession, regardless of our place of work, to think about transition in our own practice. So the first tip is to think about process. So one important aspect of transition and the definition is actually it's around a process over time. So I think we all in our own practice need to think, how do I think about transition as a process in my own practice or place of work? One of the things that we can start doing is thinking about the process of transition early. Often, no one answer, but often I say, why not age 12? So as you turn 13, just as a trigger, let's start thinking about this transition process, which will happen over a number of years. And how can I set up my practice so I can start thinking about this early, having discussions early with young people and their family. I think just talking about transition is a really good start. And we did a survey, it was many years ago now, it was about 11 years ago now, and just within the New Zealand context. And what's really apparent is, and I hope we've got better, and this is more a paediatrician thing, and so I often think my allied health colleagues are probably better at this, but that overwhelmingly, although paediatricians weren't talking about transition, parents and families were worried about it. So actually start talking, and even if it's not the message you want to give, hey, we've got a service that looks exactly like ours and I know them really well and I want to really match up with them. Even if you can't say that, start talking about it early because it's likely the families and young people are starting to think about it. There's something in process as well about actually seeing the patient, and I say this because we're all in services that are evolving models of care, and that's very appropriate. And often models of care are evolving to models where we're more doing pieces of work and discharging. That's appropriate as well in many settings. I think we also need to think that's important to evolve models of care, and how do I make sure that we think about the process of transition as we develop models of care for our adolescents. I think, and this is probably self-evident, but nonetheless I come back to it, I think the second tip is provide excellent clinical care. And by that I mean, as we are coming in and providing pieces of work and stepping away again, there's often actually a need in whatever is our piece of work, because that's what our profession says our piece of work is, actually not necessarily just doing the bit in front of you now, but actually thinking about that stuff in depth, because there can be things that have happened, and often it's worth having that conversation with families. In this area that I'm working, is there anything that's been said to you when your child was younger that was going to be picked up later? Is there anything that you're unclear about? Is there anything, often in my area, it's actually around diagnosis. Someone made a diagnosis when a child was 2. Have we really succinctly put that in the context of a diagnosis that is easily understandable and relatable to, that will be understood by my adult colleagues at the particular age we're at? And I know in your profession, wherever you're coming from to this talk, there will be certain things that you think, yes, it's worth putting that thinking cap on about the clinical care, so that we can be really confident in the whole package of care that we have done by the time they leave my service. And within my service, we actually like to start having those conversations about 13, because we do like to get any referrals that need to be done while they're still under the paediatric system. And it's not at all surprising to have someone say, oh yes, Someone said when my child was 12, we should be referred back to the orthopaedic surgeons or la la la. Good time to do it now so we can get things as sorted as we can before we send into the adult services. In my particular area, this is often actually around starting to really think about annual screening or other guidelines that might be relevant for adults or young people, and actually getting those out in front of everyone so that we can all start working together. And in my area, this is actually often around starting the concept of annual health checks and linking it with GPs. But you will have in your own areas, what are the things that would make better clinical care or improve clinical care for young people in your area? I think it's always important to quite specifically plan for the future. So actually anticipating those future needs. Actually, in the area I work in, what are the preventative needs that might come up in the future? What are the acute care needs? And what are those more chronic needs, care needs in my area that could actually need to be addressed? And actively thinking about those things. And then starting to actually plan around each of those ideas. What would happen if this young person turned up to hospital at 3 o'clock in the morning? How would that care be done? And can I help my colleagues who might be trying to deal with this young person then to actually address that the best way it can? Tip 4 is around what I call handshake. So the first thing is it's really important to have a positive attitude. So it's not actually about, hey, it's really terrible, it's really hard to get anyone with this particular, I've been doing a really good job in this area, but it's really hard to get any of my adult colleagues to hear that. Actually, a different attitude around, hey, the adult health system works differently, but actually there's some really good people there, and part of this is going to be around how we equip you guys with some tools in your toolbox to understand and know how to navigate that adult system. I think it's really important to make the effort to meet your colleagues and work collaboratively on the system of transition. So it's not just a handover, but it's actually a handshake. I think often if we're the ones working in disability, then actually thinking about disability access, both from physical access, communication, health literacy, and often these things are not so well necessarily addressed day to day in the adult healthcare system. So how can we equip these young people to be able to, in the best way they can, access the adult healthcare system? And I think we may not feel like experts in this, but I think we are, and I think we should actively think about this. I think that it is often our job, if we are working with young people, we need to think about youth health. We need to make sure we can put that youth health lens on the disability perspectives that are happening. For me in my practice, that's been upskilling in heads assessments and managements to, where appropriate, have appointments alone with a young person, and to ensure that I'm really thinking about all that teenage stuff. So just because you have cerebral palsy, put it the other way around. You have cerebral palsy. Of course, I need to think about sexuality. Of course, I need to think about drug and alcohol assessments. I need to think about all that same teenage stuff and have the skills to be able to deal with that. I think we are often the ones, if we're in front of the family, we need to think about that family and what their long-term needs are. We're often having discussions with families about decision-making. They may need to go through processes such as welfare guardianship. But I think most importantly, document this so our colleagues in the adult system know the discussions that have been had and can optimise their working with the family with the information that we have in place. I think we need to really optimise our documentation. We need to think about, often the young people we deal with have information in different systems. Certainly locally, there's different systems, every computer systems informations have. There's often actually huge amounts of information about these young people, but how can we get the right information to the right people at the right place at the right time? There may well be what will work in your workplace. ADHD is working towards transition templates, so there's one place for our adult colleagues to go. I think technology has a really big role here. I often have young people photographing their own clinic letter so that they have that easy to hand themselves. There's a big role for patient-completed documents such as health passports, but I think exploring what's going to work in your workplace to get that professionals and young people need the right information at the right place at the right time is a really good thing to think about. I think that often when we're working in this area, no one clinician is the expert. So how can we, whether we are paediatric providers, whether we are adult providers, whether we're working in hospitals and community, how can we talk about this stuff and upskill each other? Because often the best care is everyone bringing their part of the puzzle together. I think although I talk about the small picture of the bits of the jigsaw that we can do tomorrow, I think we also need to continue to raise some profile, we need to advocate for young people, we need to support research in this area. But I think the most important thing day to day is actually very, very specific. Be very specific in your own practice. I am thinking about transition, and these are the things that I am going to do in my practice, and then working with the young people to support young people and their families about what and how they can be empowered to improve their knowledge and understanding and navigation of the adult health system. I shouldn't really be talking to you guys about goals because this is the one of the areas I'm very aware that allied health do very well thinking about goals with young people. And what I would suggest or wonder is whether there might be opportunities in school IEPs within that day-to-day work we're doing about actually having goals around health literacy, transition of medical care, optimising health and well-being as the goals that we sit along young people with. In a very practical sense, this will often come down in my clinics to things like talking about do you have a general practitioner? Do you have a general practitioner you like seeing? Would you like to have a think about, is your general practitioner about to retire? Because often they are, just as our young people reach their age. Would you like to think about and talk around in your community about who would be a good general practitioner for you in the long term? So we're actually signalling it as something that the young people can come and talk to us about in a year's time. That's within my context of clinical performance. So I think that in most services, there's a very long way to go towards optimal transition services for young people with disabilities. And I'd love in question time to hear about services that are actually starting to progress along here. We're doing some work at ADHV that might be good to think about on another occasion. But I'd really like to leave it with you that I think if you're working with young people, you can do something sensible today that really strongly supports this idea of transition of medical care. And I think it can actually make a real difference for young people.
Thank you, Colette. Really practical thoughts there and really, really good food for thought about how we're practicing with our young people and having those conversations early. There was a couple of questions around model of care, and one of the questions that came through was around whether there were any specific model of care that you were particularly thinking about, education or health, but also perhaps thinking about the F words as a framework as well for these conversations, and one of the F words I guess being future, but
yes.
Just your thoughts around that.
Well, we're doing some work locally around this at the moment, and I think it's always, I don't have any particular thoughts other than I think this work can very easily map onto the models we already have, rather than necessarily needing to bring in new and different models of care. So we've been talking locally, for example, to our local specialist school and looking at setting up, and it's a way off, but looking at actually whether we can trial putting concepts of transition into and alongside IEPs. So actually using that model of care of review and teaching and skills and knowledge that comes into the IEPs, and can we put this in there as well? And we've had a huge amount of support in thinking about how we might do that. So that's very early days. And I think the same comes up with the F words. I think absolutely this fits in really nicely to that. And I think it is much better to do this as a, yes, let's put this in as well, because this is dry and it's not interesting, and it's probably often unlikely to rise to the top. So it might be that way of actually, can we have our mindset in and put it in alongside? Is mine. Now, when we think about broader models of care, of course, you know, I can, you know, when we look at disability models of care, and I apologise, well, you know, more talking from a medical perspective here, that the models of care that work for improving medical care for young people with disability internationally seem to be people setting up adult services that work in a similar way to paediatric services, where you have those that work super well, you know, come in and see your paediatrician and other members in whatever their context is of a wider multidisciplinary team, and really work the same way. My reflection on that as well, that often provides really good care for a very small number of young people. But nonetheless, there will be times where it would be great to get funding to do that. I think more importantly are models of care that actually support what a GP does and how a GP actually works. And I think that we in paediatrics often do a good job of providing care in our hospital and medical systems, but missing that link of the GP. And I think getting the GP in as part of these discussions, I mean, I'll put it out there, how much, you know, is a really simple thing, how often do we send updates of child's goals and progress to GPs, let alone ask GPs to pick up some of that work and carry it on? So, yeah, lots of different things to think about.
Thank you, Colette. Yeah, there's lots of things there. There was a comment on the chat from, sorry, I'm not quite sure who it's from, but around Ministry of Education and MSD are piloting a new program using COVID-19 funding, which is looking at employment service in schools to support young disabled students prepared for employment. So that's something useful to know about, that we can actually make ourselves more aware of. And there are a couple of other comments there about how, you know, we can support society a little bit more to really engage and accept and embrace those people with disabilities. And comments there from Fee about, you know, perhaps looking at the Paediatric Society joining, becoming an advocate as people that work in this area. So yeah, something really great there. And there was another question around strategies around health literacy for young people, Colette, just whether you had any strategies there for health literacy for young people.
Yeah, I think we run the risk, I'm talking about paediatricians here, of I'll put it sorry, but I'm just saying. I think the first thing we need to do is all join up. So, you know, we need to be joining up with the knowledge that our therapists in schools have, and we need to be, or the information that Explore have about young people, because I find that often lots of people are doing work, for example, around communication or about learning and how this young person best learns or communicates. And I think our best start is to actually try and pool all that information. So rather than us thinking this is a new thing for us in the house to be thinking about health literacy, should we be sitting alongside what schools are doing and saying, hey, tell me what strategies are known by this young person and their whānau and their teachers to work, and maybe we could use those strategies to help build on health literacy over here. And ditto, maybe if we can improve the knowledge about the specifics of the health system and feed back into the learning that happens at school. So I think there are resources, and I'm happy to put on some of the things that I have, but I do feel that use what we already know as the basis for health literacy. Personally, I use a lot of visual strategies, and in my clinics, I find that really helpful.
Thank you, Colette. I think that's all that we've got time for. A really interesting discussion, and it's a topic that I think many of us, you know, look to do better, and you know, and to upskill ourselves with. So I thank you, Colette, for coming and sharing this presentation today, and really value your voice in this area, hearing what you've got to say. And I just wanted to again to say thank you to everybody for joining today. And as I said, you know, if you are interested at all in joining up as being part of the group that helped put on these Lunch and Learns, then there's a great opportunity there. We would welcome you as part of the team. And thank you, everybody. And
can I just interrupt and remind people that next month we have Mindy Silver coming to present, so that's going to be a great topic for people to come back to. And this chat, this forum, there's been like over 60 people joined today. So Colette, I think it's a recognition of the passion that people have for children and their families about transition, and also for wanting to listen to your talk. And maybe if we keep the chat open for a little bit, this might be a great way for people that are passionate about this to think about joining a little group. Maybe that can be one of the things that we explore in the Paediatric Society. So if anyone is passionate about that, please we'll keep the chat open, message me or contact us. Mindy Silver's topic is the use of technology in supporting children and their families. So yeah, message me if you're keen to continue this discussion about transition.
thank you, Jane. And thank you, everybody, and have a great day. Thanks for joining.